Okay, everybody, welcome to the show. I have a very exciting guest on today that will be on shortly, but I thought that I would take some time to let everybody know why I've been concentrating quite a bit on medical guests and talking about things that pretty much affect everyone when it comes to our healthcare. The main reason is because I come from a family that had that of doctors, and I've always been interested in medicine and always believed that we should trust our doctor. But in the last 5 years, 7 years, I have not trusted doctors very much and have questioned more than ever the field of medicine, and from the pharmacies to the doctors to the surgeons to just about everybody involved in it, the nurses. So I wanted to concentrate on trying to get some answers. So, as you know, I've had Kim Witzik on, whose husband died from taking a medication that was not labeled. And that was a very interesting conversation. So I'm now focusing on what we eat and how that affects us. I want to talk about biohacking, which I've become a member of that club. I want to talk to doctors about the elderly care because that's affected me with my father and my mother. And I want to talk just in general about what has happened to the healthcare industry because doctors who we once always trusted, we're now not trusting. So I want to find out why. So today's guest, Dr. Victoria Sweet, wrote two books. She wrote a book called God's Hotel, and she wrote a book called Slow Medicine. She's compassionate. She's unique as a physician. She now is a clinical professor at UCSF in San Francisco. And she wants to talk about where and how physicians have lost that passion or compassion for their patient and how we've become, or doctors have become more mechanics than gardeners. So, without further ado, please welcome Dr. Victoria Sweet. There you are.
Oh, it's fine. I
Hello.
haven't used this for a while. Hi.
I want to just thank you so much for being on, Dr. Sweet. And this conversation, I should start out by telling you that, well, first of all, I did an intro about you, so that people know everything about you. I'm so grateful that you're here. I should let you know that one of the reasons that I really look forward to this conversation is I come from a family of some doctors in the family. And, I always was a person who very much trusted doctors. And until the last 5 years,
Mm, well,
things kind of went upside down.
uh-huh.
And now I've become kind of a patient advocate for my loved ones, for my family. I'm reading medicine as if I've become like a little understudy as a physician. um, and my mother went in for a routine
Hmm.
surgery at 81 years old to get a heart valve repaired.
Hmm.
And she never came home. She never
Oh,
came home. She went in, he said,
no.
my mother looked extremely young for 81. She was in perfect health other than this heart valve. It was an elective surgery. She went in
Oh my gosh.
and he accidentally cut her right coronary artery. And he came out 6 hours after into surgery and said, "Folks, gather around.
Oh my
We
God.
might
How
not win this
horrible.
one today." That's how he put it. We might not win this one today. You know, if there were 15 of us in the waiting room, and he did it minimally invasive, which
I'm
made us
telling you,
all,
that makes me cry, actually, to be
oh,
honest. It does. It's
yeah.
horrible. Anyway, keep going, but
Well, he did it minimally invasively, and it was meant, and the way he presented it to us was that minimally invasive was much easier, better, less dangerous.
yeah, sure.
And in fact, it wasn't. It was more dangerous than an open sternotomy would have been because he couldn't see. His field of vision was not there.
Mm.
And he accidentally cut her. She bled out. They tried to take something, one of the saphenous vein, or is that what's called?
Oh,
Saphenous vein. They tried
no.
to uh, correct it. Anyway, she then they kept her alive. They put her on an ECMO machine. I'm sure you know what that is.
Right.
But when he came out and told us that, he told us that the ECMO machine was only for younger people, but he was making an exception for her because of this injury that occurred. And that he wanted us to know that he was doing something that he really shouldn't do because the hospital usually reserves that for younger people.
Oh.
And so this kind of started me really digging deeply into her records and into my brother died cardiac arrest. Last year his triglycerides were off the chart. Doctor never did anything about it. So in reading your work,
Mm.
I it just really resonated with me and I just thought, what is happening to the healthcare system? Like why is it? And especially with the elderly, I noticed it most of all where one of your books, God's
Hmm.
Hotel,
Yeah.
like what what are your thoughts about why are things so different now than when you started?
Wow. First of all, I feel really bad about losing your mom because if there were 14 people in that room, that says a lot about her.
Yeah.
And I'm very we have a very close family also, so I'm very close to my mom. And my mom was 98 at the moment. And I'm just, you go when you're younger, you're like, well, your mom's 98. Like, what do you expect? But on the other hand, I've been friends with her my whole life, you know? She's a person who's been in my
Oh,
life for all my life. So you could say it's, of course, she's old, so I should expect her to be gone. But actually, I think it's sort of the opposite, you know? If you lose your mom when you're 4, okay, you've had a 4-year relationship, but, use it when you're our age. So I feel terrible for you, and what a, you know,
thank you.
horrible, unexpected, just totally out of the blue, right? So I just want to
Yeah,
say that for
thank
starters,
you. Thank you for that. I
and I
appreciate
mean it deeply. And you ask a fabulous question because that question is what I've been working on the last 5 years. Is what has gone on with medicine. And I actually have finished a book that should be out in September. It's a bit of a long story, but the short story is I asked myself this question. Because on the one hand, it's rather ironic, right? On the one hand, we have unbelievable medicine. If I compare medicine today, the actual practice of medicine, what we can do, the medications we can use, the diagnostics we have, the results we get, it's absolutely phenomenal. And so on one hand, we should say we should all be just every morning getting up, kissing the ground and going like, this is phenomenal. We get to live now. I mean, I'm a little older than you, but not that much older. But just as an example, I think about this. My great grandparents were born in the 1800s. When they were born, there was not even any anesthesia.
it. Right.
My, people we know, I mean, I never actually met them, but pretty
Yeah.
close. They met me, but I didn't know I was meeting them. And I mean, it's just unbelievable. We don't even think about it. It's like only been 150 years. They had breast surgeries
Without
tied
anesthesia.
down. Not that in the 1890s and the early 1900s. So we've come so far, even when I was in medical school, just to kind of give you, because I want to kind of, so this is how I think of it. I do, like, on the one hand, it's phenomenal. So when I was in medical school, the kind of, just to give you one little example, the way we could see in the brain, we had just gotten CT scans, just barely, but not even really yet. It was just a horrible, it was called a pneumoencephalogram to sort of see what was going on in the brain. It was just a ghastly procedure where we injected air into the brain so
Wow.
that it would, that against the air, the soft tissue of the brain, we could see it. It was horrible. It was painful. It was dangerous. That's all we had, really. I mean, we had brain
Well, the
scans.
patient was awake during this.
Yeah, yeah, sure, because it was like a test.
Oh, geez, God.
So now we have these MRIs, particularly. Then we had CT scans, which were pretty good, which were fabulous. But the MRIs, like every other day, some of my friends go for an MRI, and they get these pictures, right? Just a miracle. That's just one little thing. And yet, on the other hand, everybody is, and rightfully, um, very upset, rightfully so. you like your example on, just of him, the whole way he handled it, right, was just, we're
It
just,
wa it
what's up with that?
we might not win this one today, like we're in a
Yeah.
ball
What,
game.
yeah, what is it, a game?
Yeah.
Exactly. Exactly. And that's just sort of the doctor, but there's a deeper, much deeper thing, and that's what I've been working on the last several years, trying to figure it out. So this sense that we've been ripped off, that the financial, well, I don't know the sense, but the essence of the matter is that the financial system
Mm.
discovered healthcare as an amazingly profitable um, pot of money about 25 years ago. And they have meticulously, as mostly as private equity, been buying up everything. And when private equity buys things up, they have a plan they follow, because they want to buy something up and they want to get rid of it in 5 years, and during that time they want to make about 20-30% of their money. So
Right, right.
it's a long story. And so with the book that will be out in September, and if when we get off, I'll send me an I'll send you one, because I think you'll be interested. I've written it as fiction because I really wanted to engage the reader in the stories, but it's based on, everything in it is factual about the kinds of ways they go about sucking money out of the system, and therefore creating a system where they do shortcuts, where you can't find a doctor, where it's just bizarre. You get charged $2,000 for a pill that was $100 last.
Well, that's the thing, doctor. Do you think it's like, does it stem from you? When we're going to talk about Laguna Honda Hospital and how this all kind of came about for you, but
Mm-hmm.
when you look at the insurance companies,
Mm-hmm.
big pharma, the doctors being coerced into certain kinds of medicine because they've got the reps out there working it, getting the doctors to prescribe certain kinds of medicines. I
Mm-hmm.
mean, it's just this huge machine.
It is.
And where is the care? Where's the compassion
That's
from the
right.
doctors? It's probably not what you learn in medical school. Don't you learn more of the compassion side of it in medical school or not anymore?
Well, we don't have to learn the compassion. Actually, most people, at least more than 50%, but even most people get interested in medicine
Right.
not only because they're compassionate, but it's certainly part of it because it's a hard job. It takes a lot. So what's happened, it's led to a huge burnout of doctors, because as finance ate the hospital systems, the private practices, the MRI machines, the labs, the medical, everything, there are more and more strictures on doctors that are hidden. Some are hidden from the doctors, and a lot are hidden from the patients.
Well, there's protocol, right? That doctors have to follow.
There's more than that. There are protocols, that we're supposed to follow, and it's that's why I ended up writing this book, because I don't think if I give you one or two examples, you can kind of realize. So I actually have, I put it.
What's the name of the book, doctor? What's the name?
Oh, you can see because
Oh,
it's mirrors.
convictions.
Yes,
Wow.
and it's money, greed, corruption, courage, integrity, and grace. It's
Wow, I
both,
love it.
it's both about the money, greed, and corruption, and then the doctors, sometimes the administrators, sometimes the patients, who, at the risk, quite a big risk of things, they fight against it. And the subtitle is A Story of Medicine in the 21st Century.
Oh my gosh, I can't wait to read it.
And so it's based on, I spent years figuring it out with the help of a friend that you'll see. And I actually have written it, but I've written it as fiction, and I've written it there, with the idea of almost like a TV series in the background. So it's got the pace of a streaming series. So
Oh,
you
well, that's something else I do, so I can't wait to read it.
you meet you meet the characters, and they kind of intertwine, but it's all based on, what's really going on. And I decided to write it that way, because if you just tell the individual stories, this it just you can't kind of get it until you get actual characters involved. So I'll send you a copy.
Oh, amazing. I
My
can't
memory
wait
get
to
off.
read it.
Okay. So,
You know, it's incredible too when you think about when you go to the hospital and a friend of mine was here and his mother was sick. She's from Canada. She goes to the doctors here. They want at the hospital $10,000 out of pocket for an MRI. You go to
right.
one of these
Yeah.
Halo diagnostics and it's
Yeah.
$700.
Yes.
So then there's all of that going on. There's so
Right.
much going on. One of the things I wanted to ask you about
Mhm,
was
mhm,
something that you said that was so beautiful that I read about the doctor as the mechanic versus the doctor as the
mhm.
gardener. Can you explain that? Because that's such a beautiful metaphor. I just really love it.
The more I practiced medicine, the more struck I was by things that didn't fit into the uh, mechanical paradigm, the logical, mechanical bodies made up of cells and DNA and blah, 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 and the tendons are in the thigh bone is connected to, and all the stuff that we know, the immune system, all these wonderful, brilliant discoveries of the last 150 years. But the patients I saw, what stuck out is the patient who would, their cancer would just go away one day. There are patients like that. They just wake up in the morning, it's gone. Or this whole relationship between patient and doctor, which I gradually realized was so powerful. Um, and they didn't fit this paradigm. So I was struck by that. So I started reading kind of the non medical literature. And gradually I became aware that I was missing a whole understanding of medicine that used to be available to docs before this wonderful mechanical medicine that was created in the late 19th century. It began. This idea that the body was best understood as a machine made of parts called cells. And again, it was a brilliant way of approaching it. And almost all the work that we've done in the past 150 years have been with that approach.
Right.
But behind that, there's this forgotten understanding of the body in a different way. And I began intuiting about, finally, I ended up going back to school and getting a PhD in pre modern medicine. And I particularly focused on the Middle Ages because it was the most pure, and on a particular person who ends up being a saint of the Catholic Church, but she was also a medical practitioner, and her name was
Mm-hmm.
Hildegard of Bingen. She was a mystic and a theologian, but she was also a medical practitioner, and she'd written a book on her medicine that was in Latin, but a very simple Latin. It was clear that she actually practiced medicine, and I studied that book, and that was the source of my PhD thesis. And as I read that book and thought about it and worked on it and spent years, at some point I realized that behind her model of the body was a pre-modern model of the body, which was not body as machine, but was body as more of a plant. Because and in her time, part of that was related to the fact that uh, doctors grew their own herbal medicine, herbal.
Right. Of
They grew
course.
the plants in the garden. They understood plants. They didn't understand the body the way we do it because they didn't autopsy bodies. They didn't cut it up. They didn't have microscopes. But they this relationship between the environment around the person, their patient, the plant, what they do to that, the healing power of the plant, how a plant, if it's not doing too well, what do you do with it? You fuss and you
Yeah.
feel, you kind of blah blah blah, and that was their natural mode of dealing with patients. So she kind of focused, got me to understand, start thinking about this other model of the body as a plant and the doctor as a gardener. And as I was also practicing medicine, I realized that they're both useful, both of these ways, that there's many times where for myself and my patient, it's best to look at it as the body's a machine. There's a broken part. Can we fix it, repair it, or replace it? But
Hmm.
there were also times, especially before the patient got sick, but was getting sick, and after the patient had the mechanical procedure, there was also a time where being more of a gardener and stepping back and looking at my patient in the context of his or her environment and asking myself, what's what's the strengths of this patient? What's contributing to their healing powers? And what's in the way of that healing power? And in
Interesting. Yeah.
in God's Hotel, I talk about a particular patient who really um, kind of I got to see that because she was a patient with an enormous bed sore that
Yeah, I read about that. Yeah.
mechanical medicine had tried to heal, grafts and stuff that, but she was a street person, right? She smoked and she drank and she had a boyfriend and she lived on the streets. So all the mechanical stuff was wonderful mechanically, but as soon as she got discharged with her huge bed sore covered with the graft, she'd
Yeah.
smoke and she'd drink and it would heal. So eventually she ended up under my care at Laguna Honda with this enormous bed sore. And there was no more grafting to do because it was too big. But
You
the
said her spine, you could almost see her spine.
You could see her. I could just, when I was looking at it for the first time, I could see her spine
Oh, Lord.
at the bottom of it. And I was going like, you know, this is going to take forever to heal on its own. Um, what can I do to encourage the healing? And so I thought sort of the opposite. What's in the way? She came in, and by that time she'd been in and out of the hospital for about a year. So naturally, she was on 26 medications at that time, which she'd all collected the way our patients collect them, right?
Yeah.
Somebody put her on medicine for hypertension, they kept it on then this and that and that. And so I started weeding out all those medications, and then looking at what was in the way mentally, psychologically, um, and that bed sore did heal. It took about 2 years to heal.
Well, you took her off medications then.
I took her off. Yeah, I took her off. I don't like medications very much. I mean, so at the end of 2 years, I had watched that bed sore heal on its own. And it was actually then that I decided I was going to try and write a book about what I'd been seeing because nobody gets to see that anymore. Now, we used to get to see it, right? But
Yeah.
doctors don't. They see a patient for, you know, and then they get discharged and back and forth. And I was in this very strange old fashioned hospital that had been built in 1926. It was the San Francisco Almshouse originally. And it was a big old fashioned place that had escaped modernity up until about 10 years ago. Good news, bad news. Obviously, we still had, we had everything new, of course, but we didn't have this huge pressure to discharge patients. Patients were on big open wards. They might be there for 6 months or 6 weeks. It was a long-term care place, but not, anyway, it was so fascinating.
And in almshouse doctors, excuse me for asking, but the almshouse mental or I guess what it is basically some who funds something like this, and can you explain what that is? Because some people don't know what that is.
An almshouse, an almshouse is a very old, so traditionally, before we had health insurance, we actually had a way of taking care of patients. And it was a system in the United States that actually came from Britain when the United States was first founded. And the British system goes all the way back to before the Middle Ages. And it was a system that was spread throughout Europe. And the system was that every county had a big old county hospital
Mm-hmm.
for the acutely ill, people that, whatever, that anybody could go to that was free. Now it was funky, okay? It was not fancy, but anybody could go. That was sort of the basic underlying safety net. And then if you needed more care than you get in a county hospital, there was another hospital-like item that was called the almshouse, which was for everybody else. So we used to have a system where we had a place to send people that we didn't know what to do with. So this is where the homeless used to be, and the mentally ill,
Right.
and orphans, and pregnant unmarried women, and
Free
scoundrels.
of charge, though, like
Free of charge. It was
funded by the government or funded privately
good
or by.
question. So the funding, and so that's that. I'll get to that in a second. So that was a system that was brought from Britain, and that system in Britain arose and throughout Europe actually from monks in the Middle Ages who took on the care of the sick as part of their monastic tradition. And this goes way back. It goes back to around 380 AD.
Wow.
When monks started to form in groups, and that was one thing they took on because of a passage in the Bible where Jesus says, whoever you take care of, when you take care of the sick, you take care of me. So it
Mhm.
was their tradition in action.
Mhm.
And so throughout Europe, there still is many of them exist today. And that's how I got the name for my other book, God's Hotel. because God's Hotel comes from the French Hotel Dieu, which was the name in French for the English almshouse. So this system got brought to the United States. It used to be, before we had health insurance, that every county in the country had a big old county almshouse that was free, that was funded by the county. Get back to your question.
Hmm.
And a big old almshouse that was funded by the county for everybody else. And it's actually a pretty efficient and pretty inexpensive way, because typically the care would be given by medical students, residents, trainees, nursing trainees. They'd have staff over them, and it was, not fancy. It was just
Almost
not.
like a teaching hospital? Was it?
That's where we get the whole. It was a teaching hospital. And what happened was is that in the 1950s, most of those almshouses were closed across the country for two reasons. The left didn't like them because the care that was given there wasn't equal,
Mhm.
wasn't as nice, it wasn't as pleasant, and the right didn't like them because it was expensive. And the third reason was because most of those almshouses were had been established when the cities were established in the 1800s, and they were on these beautiful pieces of property. And it's a system I think that we miss. I think it would be good to have. It's like a safety net for the safety net. It would be good for all of us, I think, to know that if worse came to worse and we lose everything and we get sick, we can always go to the county hospital. I like that.
Right.
I like that idea. Just let everybody go.
Yeah, I like
Um,
that too, but that's
so
just not anymore. That's
right.
sad.
And so because
Not.
that it was this big open place, I got to see, in the almshouse typically would get the bottom 1/10 of 1% of people, right? They'd
Yeah,
get the people who fell through the holes in the safety net. So they would get, um, and we got them, everybody,
yeah.
everybody. Some rich people that had fallen on hard times, mentally ill people, poor people, old people, it was everybody. We
So
had,
when you talk about this in your book, and because you wrote 2 books, Slow
yes,
Medicine,
I
and
did.
Slow Medicine is also looking at the patient as a whole. I wanted to ask you about polypharmacy in particular.
Mm,
You mentioned it earlier,
yeah,
about your hatred of medicine, and not that I'm sure recognizing that medicine is very helpful in some cases,
yeah,
antibiotics, things like that,
yeah,
painkillers.
no, it's good.
That However, like I'm dealing with that right now. That's another issue I'm dealing with. My father, 86 years old.
Mm,
He's on 20 medications. 20.
so,
How do you help people, your parents, your grandparents, your aunt, your uncle, people who are elderly? How do you advocate for them when you have so many cooks in the broth and they're just getting, the pharmacist isn't helping out. So what do you say about that? Like it's
I think
frustrating.
it's a super good, very, very good point. In fact, I think some of my best cures have been just by taking people off the medications. I mean, honestly. That said, I don't hate medications, but I do hate too many medications.
Yes.
I think our medications are wonderful, but it's actually quite tricky. So I'll give you three sort of stories, and then I'll sort of summarize. I like telling stories.
Oh,
I,
I love it.
I find, I mean, not long stories, but that's how I think of things. So, for instance, with my father, when he was in his 80s, and I was at a distance from him, and the short story is, he had a cardiologist, and then he had an arrhythmia guy who was also a cardiologist, right? But
Hmm.
just did his
So
arrhythmia.
two cardiologists.
Yeah, that's right. He had atrial fibrillation, if you know,
Hmm.
the irregular
Yep.
heartbeat,
Yep.
and so at some point, he was really frustrated because he didn't like how he was thinking. So I had him read me his meds. I was in Switzerland at the time, so I was living there, so it was all on the phone. But I realized he was on two of the exact same medicines, but under different um, names.
Hmm.
Exactly the same. The cardiologist had given him one, and then without knowing that the cardiologist, the arrhythmia guy had given him the same one, but there too. So my dad didn't know, so he's getting twice as much. So that's just an example. And then
Perfect
trying to
example.
call the arrhythmia guy and call this and try and get my father. Even just that one little thing took a while. That's the first story. So even as a doc, even you're right, even as a doc who knows how to talk to and get in, and it was tricky. That was the first one. Then I'll tell you now, it's actually a related story. It's also with my father. He has a surgery, wonderful surgery. They zapped his the little focus that causes atrial flutter.
Oh, they cauterized it?
They
Yeah.
caught it right. Magic. I mean, again, he was like 90 at the time. Like
Wow.
amazing. They would do it. They did do it. Worked great. So mazel tov to them, right? On the left. Great. But then he gets out and he's in normal sinus rhythm. Ka-pum, ka-pum. Very nice, very nice. Blood pressure.
Mhm.
Ka-pum, ka-pum. So when he first gets out, they put him on a blood thinner. Okay, because when they first, but then after about 2 months, I'm going, he's still in normal sinus rhythm. Why does he need to be on a blood thinner? And he's an old man and he falls. And if you fall and you're on a blood thinner,
Oh,
you're
the worst.
screwed.
Yeah.
So I call up his other cardiologist and I say, do we really need to keep my dad on a blood thinner? He goes, well, I think it's, we certainly don't want him to have a stroke. I mean, have a blood, get a blood clot. I said, yeah, but he's in normal sinus rhythm. And his likelihood of falling is greater than his likelihood of. Anyway, I insisted. I insisted. So they took him off. So he never had any problem after that. But it's not easy. So those are two stories to say. Even for me, and I have distinct notions.
You're a doc
I'm
talking
a
to,
doctor. I
yeah.
have a lot of experience. I'm quite confident with
Yeah.
my stuff. Um, Even then, that's why I want to. So that's the second story, and the third story was at Laguna Honda, I took the average patient would come in on about 20 to 26 medications because I kept track. That was typical. What your dad has, he's missing 6 of his medications. He should
Wow.
have 6 more.
You could have, geez, I
No
can't
idea.
even, yeah.
And so I get people like, and I would just slowly, right? I try and figure out, first of all, did they have high blood pressure? Because a lot of people have high blood pressure when they're middle aged. But then by the time they're old and frail, they really don't have very much high blood pressure and they need the pressure they have. Does he really have the diabetes or did somebody overdo? Does he need the blood thinner? Does he need these things? How did they get? Does he need a statin? Did he, et cetera, kind of go through. And then very slowly, gradually, one by one, because I had time because Laguna was such an old fashioned place.
Yeah.
I
Yeah.
could just slowly taper them off, watch the patient, da 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 da. And most people I could get down to about 5. That would be of these
That
patients.
would be ideal. Yeah.
That would be about as good. I couldn't, they did need the other ones. And so I was so interested in that. This was at least 15 or 20 years ago. I had the pharmacist. We did a little study. He had pharmacy students. So I had them do a study of doing that across the hospital and then keeping track of taking people off, tapering them off their blood pressure medicine, tapering them off their GERD medicines. They're all on
Yeah.
that, which didn't seem like a good idea to me to stop your own body's acid for no good reason.
Right.
And the
Right.
third one was people who had diabetes, but their sugars were normal. Did they really need it? And so it was very interesting. So we did it. This wasn't to be published. It was just for our own interest. And
Right.
about 40 to 50% of the time, you could taper the people off those 3 medicines slowly. So that's pretty interesting.
Well, you wrote a story, or I read a story that
Yeah,
you wrote about another one about your father, that he had a grand mal seizure.
yeah, yeah.
That he had this seizure, that they thought he had a stroke. You said no, he just doesn't have his seizure medication, and they insisted upon the fact that he had a stroke, and you
Yeah.
finally discharged him from the hospital.
I didn't. It was tricky. It was very
Yeah,
tricky. Yeah,
sounded like it.
that was very tricky because that's exactly. I must say, good reading.
Oh, thanks.
Really impressed. Really, that's rare.
But it interests me so much, and your book is so amazing, and I love, like you said, stories too, and I'm a person who tells stories as well. So I love that you, even as a doctor though, you're an advocate, and you're not getting them to let go of what you're telling them. Like, you're telling them, or to buy what you're telling them.
The docs in the hospital when they had done that. So you got it exactly right. And then once he was in the hospital and he had the diagnosis of stroke, even though he hadn't had a stroke, that they couldn't get it off the electronic health record. So every new doctor that came said, "Oh, your poor dad had a stroke, and he's
Oh,
not eating. We need to put a tube in." And I'm going like, "No, no, 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 no." I had to. But the ironic part was they had a doctor's book club, and they were reading God's Hotel while I was there.
yes, I read that.
It's crazy. So I finally,
I can't believe
the
that.
only way I could get him out, they wouldn't discharge him, and I can't discharge. He's not my patient. Um, we basically insisted he go on hospice, and because he was on hospice, then they didn't have to do all those things.
That was smart.
Yeah, it took, and then he got out, and we took him off everything, and
And then he just went back on his seizure medication,
yeah, he did.
and
Yeah, he
then he
did.
lived another 3 years.
Yeah, exactly. You got it. You remembered it very, very well.
But doctor, I have a question because it's really bothering me. Why are we ageism in medicine is something I never really gave a lot of thought to until I don't know, 5 years ago, 6 years ago, when my mother got put on that ECMO machine, which I told you in the beginning.
All
And,
right.
and it was like he was a hero for doing that. Like, believe me, the hospital wants to keep it, available for anybody else who's younger to be put on that
Oh,
machine, even though he made a catastrophic error during
right.
surgery. So all of a sudden, we're like, oh, mom's on an ECMO while she was on three life-saving devices at that time. And there was no way she was going to ever wake up, she was ever going to come out. But what I realized is what my mom needed at that point was a heart transplant from what
Ah,
happened. Had she been younger, they would have been looking for transplant. I understand that
mhm,
they don't want to get a new heart for an
right.
81-year-old. I understand the ethical dilemma there. But the ECMO machine itself, so should we not be judged physiologically rather than chronologically? Like, what about a person who's 40
Sure.
years old, who's abused his body the whole time, who's an addict, who's abused his body? He'll get the heart. But my mother, who was in perfect condition, outside and had a leaky valve, who had 7 children, 18 grandchildren's or children, and she didn't wasn't even considered. But she was probably in better health than a 40-year-old.
Yeah, yeah. No, I agree with that. I mean, this is sort of a thought experiment that I thought about because a lot of the patients at Laguna Honda were either very, very old and consequently they, outlived their family and that's how they ended up there and they were in really pretty good shape at 90 or 95 or 100 or 105. And then we had the other group, the exact other group, who were in their 30s and 40s, drug users, and they needed the they
Mhm.
needed the this, and they needed the that. And they had it, they had AIDS that they hadn't taken care of, and then they were really sick, and that whole group that were in their 30s and 40s, who would then get their new heart or their new valve and go out
Yeah.
and shoot up and come back for the second or
Right.
third time. And I started getting kind of exasperated by that. And I thought, maybe what we should do is just I had this sort of it's just a thought experiment because it's a little weird. But I thought of maybe we should have like a credit card, like an ATM for healthcare that we would say, okay, over your life you're likely to spend $2 million in healthcare. So you'd have a credit card that had, and every time you go to the hospital, they take out the money, and when you run out, if you're the drug abuser and you're on your third heart transplant, they say, I'm sorry, Mr. So and so, you don't have money left here.
Good idea, actually. I like
Well,
it.
you could never do it
You
in
can
our
never do it,
society.
but I like it.
Just this thought that, again, and that and then I continued. I was like, well, okay, so what about like if you were a 60-year-old, okay, and you wanted plastic surgery, right? And you knew that everybody in your family died at 70, so you might as well get your
Yeah,
credit,
you use
get
your
the
credit.
surgery because you're going to be probably right. On
Yeah.
the other hand, if you're somebody whose people live to be in their 90s, you're going to be pretty careful about your stuff. So it was just a way of conceptualizing. I don't think, but so you're totally correct.
When I read about you and I read about the things that your books and just really did a deep dive into you, I just had such a warm feeling about somebody who's out there really paying attention and advocating and thoughtfully advocating for patients. Um, because I feel that's lost. It's almost a lost in some regards from what I've seen personally. I feel it's a lost art.
So, okay, so two other things. And I thank you very much. I appreciate being appreciated.
Yeah.
Of course I do. Because it is something that it just makes me crazy. And what makes me crazy is, like I said, this is just wonderful. We're so close, actually, to having it amazing, and yet there's this bizarre thing that's happened that I know many, many, many doctors, medical students, residents who tear their hair out, who I get, especially, it's so sad. I get, I've had quite a few people go to medical school because of my books. And then, if you, and write me and say, well, I went to medical school, I read God's side, that's what the doctor I wanted to be. And I'm finished and I can't be that doctor. These are what's happening. I have work in an HMO and I have 10 minutes per patient. And
Yeah.
I can't review their
They
medications.
can't,
And I
right.
can't examine them. And just, man, it's just is wrong. It just
Yeah.
pisses me off. And it's wrong. So there's a whole group of docs and nurses. Oh my God, the stories I've heard from nurses about the backside. You don't see it when they say, oh, the ECMO, there's something else there. Because all of this stuff, like when they had my dad in the hospital and they couldn't erase the stroke, and I believe that from it, so he kept being treated as stroke. But then right before he was going to leave, they discovered something in his kidney and they wanted to do an ultrasound before he left, like an echo of his kidney, make sure he didn't have an abscess. And I'm like, he doesn't have an abscess. He doesn't need that. Well, we're not going to discharge him till, I don't feel comfortable with that till after we do that procedure,
Right.
which they were going to charge for before he left.
Yeah.
I didn't fight that because I know when I've lost something. But so, in terms, back to your 26 medications in the little bag, I think your best chance would be to go with him to the doc, his general practitioner, with the literal bag of medicines, not a metaphorical bag, the actual physical bag, and say, look, I just would like an appointment with my dad. He can do it in 10, 15 minutes, but you just lay them all out. Does he need this? Does he need this? Does he need this? Does he need this? That's what I did.
Yeah, and I think that's a great idea because otherwise it's just on his chart and the
And
doctor can
you
read.
don't know. You
Yeah.
can't even tell because electronic records are so bizarre. I could not tell.
They are.
Oh, my dad, I was like, what's going on? Nobody knew. So finally, after he died, I'm like, I'm going to go through his chart. Well, his chart's electronic record. So I had to, you know, anyway, I ended up, after quite a bit of effort, getting a little, they put his electronic medical records on a little thumb drive. And, you're not going to read the thumb drive like this, okay? You're not going to.
Right, right.
So I had it printed out at Caicos. It was 800 and 932 pages
Holy smokes.
for a week.
A week?
Mhm. And because it was printed out, I could go through page by page. I went through all those
Mhm.
pages. I'm a very determined person. I go through all those pages. And at the end, I still could not tell you what medications he was actually taking.
Crazy.
Because there was never, the pages where they prescribed medicine with here, and the pages where they took him off was here. And then in the middle, I couldn't tell what he was taking. So
Wow.
there's all these
So how
different.
does the patient ever do it? You're a doctor reading it. Like, how does a patient, if they want to look at their chart, understand anything? Especially an elderly patient.
Well, why should they have to understand anything? The other way, I put it back to you and say they should have a doc who's a good doc who has the time to do a good job. Who they go and say, Doc, I don't really understand why I'm on 26 medications, and the doc has the time to go like, you are really?
Yeah.
Next time you come, you bring it. I mean, we should have that role. I don't think patients should have to or be expected to.
But do you think, doctor, that I mean, too, medicine has changed a lot with these urgent care centers. Like, how many times do people go to urgent care centers? You're not going to your family doc anymore
Um,
because you can just run over to the clinic. And so you're not getting personalized care as much because you're not seeing one doctor who has a comprehensive view of what's going on.
right. So not only I'm not crazy about lots of medicines. I'm not actually. I think as long as you can stay away from doctors, you should stay away from them.
Yeah. Yeah.
No, I mean it. And the thing is, so urgent care, they have a place, actually. I'm not a, I think if you're not sick, you should stay away from docs. And if you go to an urgent care and you get something because you got an hour and it gets better, fine.
Yeah.
That's actually good for you. It's good for the system. Um, what happens is over your course of your life, you will end up probably with several chronic illnesses and pretty sick, and you're going to have stuff, right? And between there and here,
Hmm. Yeah.
You're going to have episodes. I have this whole thing I call the iceberg of health and disease, which is in my next book. But it's sort of like this idea that, for quite a long time in your life, you just get sick with a little something and it gets better and you go to urgent care. But gradually, you start getting sicker and sicker. And then there's some point, it's about the top 3% of people who really need the kind of care we're talking about. And that's where the whole concept of concierge care or personal medicine or having a real, that's where we should use that time.
I think back to your gardener's metaphor being, I think that all to, just to wrap that up is just
Um,
that, you know, taking care of yourself before you get sick. We're always a society of fix it, the symptom. I mean, fix the problem once it happens, but preventing the problem is something that I think the world is starting to really wake up to, is the wellness, the health and wellness kind of area of trying to ward it off before it happens, um, rather than just letting it happen. So I am very interested in that part of medicine and what's coming in the future.
yes, absolutely.
Although
Right.
then you've got the opposite. My grandmother, 104,
Yeah, I was
she ate
thinking
whatever
about
she
that.
wanted, had a whiskey sour.
Remember. Yeah, I know that's a whole other really interesting story about. They're called the super centenarians. And my mother had a grandfather who lived to be 104, right? And so there's a very that stuff is really interesting, and that's sort of a different box than the one we've been talking about, but it's more fun to talk about because so there's been really interesting work by this guy in New York called Barzilai. He got really interested not just in people who live to be over 100, but he noticed, as I've noticed, that people who live to be over 100 are actually different
Yeah.
because at 100, they don't get diabetes, they don't have high blood pressure, unless we redefine that blood pressure down to the point in which they have it. You know what I mean? But at real high blood pressure, they don't get cancer, they don't get demented, and they live to be 100, and then they just go to sleep and they don't wake up. Like it's amazing. I mean, I've exaggerated a little bit as in my tendency because maybe they get cancer, but basically, there's this group of really interesting people that are like that. And that's not quite the thing as a blue zone, but it's also, I think it's true in the blue zone, but then there's these sporadic people. And so I loved the way he started his research. Um, he started it by sending out an ask for people, healthy people in their 70s whose parents were still alive. That's how he got his group of over 100 healthy people. I thought
Wow.
that's so clever. Because, if he'd put it out for, are you over 102 and healthy? 102-year-old, that's this thing they may not be doing, but their
Yes.
72-year-old son, whose mom's 104. So he got a group of healthy 70 and 80-year-olds with healthy parents who were in their hundreds. And he's followed them and tried to figure out is there genetic? Is it what they eat? Is it, and it's very interesting work. Very,
I'm
very,
fascinated to find out the answers to some of that
yeah, it's
because
very
it's really interesting. Like, because my grandmother, I said, Grandma, why do you think you've lived this long? She goes, I
interesting.
don't know why God hasn't taken me yet because everybody I know is dead.
Yeah.
And she was so funny, but she would say it's because she ate fruit. That this is her. She ate fruit. She hated water. She did not drink water unless it was tea, what obviously is water, but
Yeah.
she would drink tea and she would have fruit, whiskey sours, and she never cared about the past,
Um,
which probably is about stress. My grandmother went through so much in her lifetime, but she said, the past is the past. I don't care what happened yesterday. I
yeah.
only look to the future.
It's almost like the biggest gift you can have other than health. It's almost like a healthy mind that you get up in the
Mhm.
morning and you're just happy to be alive and you just, like that. Because that's a gift too. Because I don't think, again, I
Being
think
able to live in the moment, being able to live in the moment.
so maybe not in the moment, but at least in the day that you've been
Yeah.
given, this
Yeah.
beautiful day that you and I are experiencing right now. That's just like a whole life. It's all like a lifetime. Like we were born this morning.
Yeah.
Now we're around middle age. No, now
Yeah.
we're sort of young adults,
Yeah.
and then we'll be in the middle age pretty soon, and then it'll be nighttime, and we'll old, and we'll
Yeah.
go to sleep and die, and then we'll wake up tomorrow. So I think that which your grandmother had, to me, that's. And then the drinking is really funny.
Anyway, I just want to wrap this up by saying thank you for this wonderful conversation.
So, yeah, I
I
think
probably could talk to you like 20 times more and enjoy each one of them and find out more information. I've just loved reading your book. I want everyone to read your book, both of your books,
Mhm.
God's Hotel and Slow Medicine, and your new one, Convictions.
Yeah.
I can't wait to read it.
Right, it won't be out till September, but I'll send you an advanced reading copy.
Please do. I will give you feedback on it.
Perfect.
I can't
Perfect.
wait to
Love
read
that.
it.
Love that. Okay, thank you
But
so much.
thank you,
It's been great
doctor.
meeting
Thank you for taking the time to speak with me and to be on my show. I'm so grateful. Really, I truly am.
you. Okay, great.
Thank
Bye-bye.
you. Have a wonderful day.